In this presentation on altered hormone regulation, we're going to be concerned with diabetic emergencies. The learning objectives of this presentation are to discuss the scientific basis for various alterations in hormonal regulations, to identify signs and symptoms of diabetic ketoacidosis, DKA, and hyperglycemic hyperosmolar non-ketotic syndrome, or Hhnk. And furthermore, to identify therapeutic interventions to promote humanistic care and well-being with persons with selected hormonal alterations, and use critical thinking in caring for persons with selected hormonal alterations. Now, before we begin our discussion on these diabetic emergencies, I want you to consider these next two slides. In the normal person, after eating, glucose moves out of the gut and is either used immediately as energy, stored in the liver as glycogen, or stored in cells as part of fat. Protein is used to build muscles, and fat is stored in fat cells. Now keep in mind that all of these processes are involved with insulin to some degree or another. In the post-absorptive state, after several hours, the body becomes depleted of fuel. So the liver will break down stored glucose for energy. It will also break down amino acids for energy and create ketones from fat to be used as energy. Now these are stopgap measures until we eat once again and go back into the absorptive state. Just keep in mind for the discussion these processes before we talk about DKA and Hhnk. Now, although type 1 diabetes can occur at any age, including the elderly, it usually occurs in younger people, such as Hhnk here. Diabetic ketoacidosis is life-threatening. It's a metabolic complication caused by severe insulin deficiency. And as you remember, with type 1 diabetes, what happens is the pancreas fails to produce any insulin at all. Furthermore, insulin counter-regulatory hormones, including catecholamines, cortisol, glucagon, and growth hormone increase in response to this insulin deficiency and reduce the effectiveness of any insulin that happens to be circulating around the body. So in essence, the body remains in a post-absorptive state. And if you remember from our slide, in that state, the liver increases glucose production. And there's not enough insulin around to actually stop the process. There's also inhibited peripheral glucose uptake because of that lack of insulin. And there's an increase in fat metabolism, and as you know, the fat breaks down. It makes acid as a waste product, which leads to ketoacidosis. Now, DKA usually develops over 1 to 2 days, and the most common cause is infection. Other causes include an error in insulin dosing or skipping an insulin dose altogether. Furthermore, there are different types of stressors that can precipitate DKA, including sepsis, emotional stress, surgery or trauma, and even pregnancy. And medications may be implicated in precipitating DKA, including thiazide diuretics, steroids, and dilantin. Now, initial labs that are taken for suspected DKA include your blood glucose, serum and urinary ketones, arterial blood gases, electrolytes, serum osmolality, BUN, hematocrit, and white blood cells. Typical findings are the serum glucose is usually between 250 to 500 milligrams per deciliter. There are moderate to large urinary ketones or positive serum acetone, and that's because of that fat breakdown pathway. There is lower arterial pH because of the acidosis, elevated BUN and hematocrit due to the dehydration, and you may have an elevated white blood cell count if you have an infection process going on. Now we're going to look at the potassium in a little depth. And remember, it's very important because if you have hypo or hyperkalemia, you can have cardiac dysrhythmias. Now if we look at my diagram here at the top, that first cell is what is considered normal, and there are more potassium ions inside the cell than outside the cell. Now if the body becomes acidotic from our DKA, the body needs an immediate way to deal with those hydrogen ions causing the acidosis. So it will move them inside the cell. When you move something inside a cell, something has to come out. So you have potassium ions moving out. So this can lead to a period of hyperkalemia. Now in the third cell, what happens is we've begun to treat the DKA with insulin. So as we treat it, the potassium moves back into the cells where there can be a period of hypokalemia. So the upshot is you need to really monitor your potassiums during therapy when you're treating patients with DKA. Now, as far as your nursing assessment goes, you're going to have signs of an osmotic diuresis because of this huge glucose overload. There will be tachycardia, dehydration, weight loss, polyuria, polydipsia, hypotension. The skin will be warm and dry and flushed. There will be visual disturbances, and the patient is really going to be thirsty. There also may be a decreased level of consciousness related to the degree of hyperosmolality. And you're also going to have signs and symptoms from the acidosis. You're going to have hyperventilation, which is your Kussmaul's breathing, where it's very rapid and very deep, because the body is trying to blow off some of the acids to correct the acidosis. You're also going to have nausea and vomiting and possibly abdominal pain, and all of these are going to be related to the acidosis. So let's look at this pathway here. We're going to look at each of these columns individually. Now at the top, we're going to start out with insulin deficiency from our type 1 diabetes. They've forgot to take their insulin, or they didn't take enough. So you'll have a decreased glucose use by the cells, which is going to lead to hyperglycemia. That's going to lead to glycosuria and osmotic diuresis, polyuria, and you're going to get all these electrolyte imbalances. Eventually, the patient's going to be dehydrated. They're going to have hyperosmolality. They're going to have a hemoconcentration of their blood. They're going to have hypotension, tissue hypoxia, decreased renal blood flow, increase in lactic acid, which eventually leads to shock, coma, and death. Now if we go down the right side, you'll have increased production of glucagon because the liver doesn't have enough insulin around to shut it off. You'll have rampant gluconeogenesis, which is the creation of glucose. You'll have increase in protein metabolism, and a decrease in protein synthesis. You'll have increased amino acids to the liver, an increase in blood urea, an elevated urinary nitrogen, and a negative nitrogen balance, which is why they have muscle wasting. If we look at the left side, you'll also have an increase in glucagon, which leads to the gluconeogenesis. You'll have increased fat metabolism, a ketogenesis, ketoanemia, ketonuria, and decreased sodium. You'll have a decreased serum pH with nausea and vomiting, which eventually leads to acidosis, your small breathing, to try to excrete the acetone by the lungs. Each of these processes can eventually lead to shock, coma, or death. So therefore, DKA is a very serious medical emergency. Now, as far as therapeutic interventions and monitoring responses go, we're going to look at each of these. As far as fluid resuscitation goes, the usual deficit is between 4 and 8 liters. You're going to begin by using isotonic or 0.9 saline to replace the depleted circulating volume. And the rate is usually 15 to 20 milliliters per kilogram per hour. Then, based on your labs, you're going to switch over to a 0.45 saline, and that rate is reduced a little bit from 4 to 14 milliliters per kilogram per hour. Now, D5.45 is used when the serum glucose drops to 250 milligrams per deciliter, so you can keep continuing on with the insulin infusion without risk of hypoglycemia. You're going to monitor the vital signs, and you're going to monitor for vascular overload and pulmonary edema, especially in those with heart disease, which we know people with diabetes are at risk for. You're going to monitor accurate intake and output, which usually requires the placement of a Foley catheter. As far as the insulin deficiency goes, as you all know, you're going to use short-acting regular insulin, and it is given IV because it's the most direct and preferred route. And the tubing needs to be flushed with at least 50 milliliters of the insulin infusion to saturate the insulin binding sites on the tubing. Because remember, you're going to be giving this at a very small rate per hour. The standard insulin drip, the ones that I've worked with, are 100 units per 100 cc's of fluid. The infusion is 0.1 units per kilogram per hour. For the average person, it's about 4 to 8 or 5 to 10 units per hour. And you're going to expect the blood glucose to decrease by 75 to 100 milligrams per deciliter per hour for the first 4 hours. And remember, once the blood glucose has come down to 250, the infusion rate of the insulin is reduced by 50%, and we hang our D5.45. So we can maintain the level about 250 for the first 12 to 24 hours. You're going to do blood sugars, vital signs, and I&O every hour. Make sure you document everything, including the results of blood glucose, urinary ketones, vital signs, mental status, and how much insulin was administered. Now, IV insulin is continued until the acidosis is corrected, and then you begin sub-Q insulin. Now, as far as correction of acidosis and to restore the electrolyte balance, once the fluid and insulin therapy has begun, remember your potassium will start to decrease. Therefore, your potassium replacement should always begin within a couple of hours after the insulin initiation, and make sure always to check your labs. Potassium levels are closely monitored, and they'll withhold them if they have a value greater than 6 milliequivalents per liter. Now, acidosis is not routinely treated with bicarbonate if the pH is greater than or equal to 7.1, because if you correct it too rapidly, the acidosis can cause a paradoxical cerebrospinal fluid acidosis, which can lead to cerebral edema. However, bicarbonate can be given for a pH less than 7, but the total amount should not exceed 3 milliequivalents per kilogram over 12 hours. And remember, it's rarely given. You're going to monitor the serum pH and electrolytes every 2 to 4 hours, along with the BUN creatinine, and assess level of consciousness and neurostatus every hour. Now, to maintain system functions while searching for the cause of this DKA, you want to get blood cultures so you can assess if they have bacteremia. You're also going to want to look for evidence of local infection, which will mean you're going to check a urine culture, you're going to get a chest x-ray, you're going to auscultate the lungs to see if there's a pneumonia brewing, and examine the abdomen for distension or tenderness. Always, always check the feet of your patient with diabetes who comes in with DKA. I'll tell you a little story. My mom was a diabetic for probably 40 years. Well, she went to the emergency room because she wasn't feeling very well, and she had a rash on her upper body. Well, the emergency room physician didn't look at her feet, and she was developing a diabetic ulcer on her foot. She didn't say anything to him about it, so he gave her a dose of steroids for this rash. Well, what happened was the steroids unleashed all that infection, and she ended up dying about 2 days later from sepsis. So always check the feet of your diabetic patients. Now, we also need to support ventilation and oxygenation by giving them O2 if they need it. In fact, they may need to be intubated and ventilated. And of course, you're going to monitor their respirations, their rate and depth. You're going to observe for gastric distension, and if it's present, you're going to have to put down a nasogastric tube to relieve that distension and prevent them from aspirating. You also want to find out information from the patient or the family as to the exact amount, type, and timing of insulin doses taken that day and the last blood sugar levels, because that's going to help you identify if this DKA arose because the insulin dosages were too small. Now, as far as patient education goes, you want to assess their understanding of that treatment regime. Do they perceive it as complex? And are they motivated to comply with it? You want to educate the patient and family of how diabetes control is related to stressors, both physical and psycho-emotional. Also, make sure they understand the signs and symptoms of hyperglycemia. There are warning signs. It's kind of like having the flu. You want to teach the patient and family what to do with short-term illnesses. Never ever omit their insulin dose because their need for that may increase. It's very important that they stay hydrated to prevent renal failure and will actually help flush some of that glucose out of the system, so they must have increased intake of fluids. They're also going to have to increase the frequency of their blood glucose management. You want to check for ketones in the urine when the blood sugar is greater than 240. And they may need extra regular insulin if the ketones come back as being positive. Now, we want to look at Hhnk. And keep in mind that type 2 diabetes is increasing in younger obese children, so it may not only be older people who are at risk for this diabetic emergency. Now, Hhnk is also a life-threatening metabolic complication, and it's similar to DKA, yet that lack of insulin is not absolute, so that fat breakdown cycle does not occur, hence they have no ketones or acidosis. This is frequently lethal. It is associated with a 20 to 50% mortality. Now, the hallmarks of this condition include extremely high glucose levels, which elevates the serum osmolality and causes an osmotic diuresis, as in DKA. The one main difference that distinguishes Hhnk from DKA is that absence of stimulation of the ketogenic pathway. Now, it usually occurs in elderly patients with poor fluid intake and often is misdiagnosed, and as I said before, has a higher mortality rate than TKA does. Precipitating factors include pancreatic disease, which may include pancreatitis or pancreatic cancer. There can be acute stresses, which include extensive burns. If they have myocardial infarction, or they have an infection. And again, drugs can be involved, which are the steroids, the sympathomimetics, thyroid preparations. Also, hyperal, as we learned in the last lecture, can lead to elevated blood glucoses and Hhnk, especially in the elderly, along with high-calorie enteral feedings. Now, manifestations of this are again caused by that osmotic diuresis. You're going to get polyuria, polydipsia, weight loss, postural hypertension, poor skin turgor, dry mucous membranes, and tachycardia. However, you're only going to see maybe shallow respiration, maybe just a mild nausea and vomiting. And here is where the difference lies between DKA and Hhnk. There's no ketoacidosis. And that's because there's still enough insulin being created, even though it might be in small amounts. It's enough to stop that ketogenic pathway. So the laboratory data are going to be similar to the ones for DKA. You're going to get blood glucose, serum and urinary ketones, electrolyte, serum osmolality, BUN, hematocrit, and WBCs. Now, their glucoses are usually extremely high, 1,000 milligrams per deciliter or greater. And actually, I had an aunt of mine, Aunt Lois, who developed pancreatic cancer, which we didn't know about. She went into the emergency room and her blood glucoses were actually greater than 1,500. And there's minimal or no ketonuria. The serum potassium may be low because of the diuresis. Your serum sodium may be high or normal. The BUN is going to be elevated along with the hematocrit. Now let's look at this pathway. You're going to begin with insufficient insulin for the amount of glucose that's hanging around. You'll end up with extreme hyperglycemia, which will lead to glycosuria, a severe osmotic diuresis, polyuria, which is going to decrease all those electrolytes, sodium, potassium, and phosphorus, which will cause an electrolyte imbalance. You'll have profound dehydration with hyperosmolality and hypovolemia. So they will have hypotension, tissue anoxia, and an increase in lactic acid. You'll have decreased renal perfusion, oliguria to anuria. You can get hemoconcentration with a hyperviscosity, and they're at risk for thrombus formation. All of this leads to seizures, shock, coma, and death. So this too, again, is an emergency that needs to be treated. Now, as far as interventions for this group, they're about the same that is done for DKA. However, there are the additional considerations. The elderly patient must be hydrated with caution due to the possibility of inducing heart failure. It is recommended that a CVP, a pulmonary capillary wedge pressure, and renal function studies be done and used to guide therapy, especially in those elderly patients with a known cardiac history. And you really need to monitor them for heart failure throughout the fluid replacement. Electrolyte losses are a major factor in Hhnk. Potassium losses are due to the catabolic state and body water losses. And the potassium losses have been reported as greater in Hhnk than DKA. So their potassium replacement should begin with 1 hour of starting the fluid replacement. And for patients with renal insufficiency, initial potassium replacement is going to be based on serum levels. Once the Hhnk has resolved, you can start administering insulin by sub-Q injection, especially once they're able to take oral fluids or meals. And the insulin may be continued for a short time, but there's a possibility that long-term insulin therapy is not required as long as you can find out what precipitated that Hhnk. As far as patient education goes, you're going to assess the patient for any cognitive limitations that may affect their ability to understand their clinical condition. Most teaching is going to happen after transfer from the unit. Therefore, you need a transfer summary, and it should include information regarding the duration of the patient's disease, their management of diabetes, any concurrent illnesses, the history of the crisis, and any financial and social support system. Now, I was an unofficial diabetic educator for Loyola University Medical Center, and unfortunately, I usually was called when the patient was in the midst of being discharged home. Well, that's not a very good time to do teaching. So the only teaching I could do was related to teaching them about signs and symptoms of hypoglycemia and hyperglycemia and what to do, and how to correctly administer their insulin. Therefore, it's imperative that you and the nurse, as the nurse, make sure that they have a follow-up appointment with a physician, and hopefully they will get much better teaching in the outpatient arena. Now, just because I think you ought to know these things, we're going to look at the onset and peak of these different forms of insulin, because you really need to be aware of these to make sure that there is a glucose source for people that may develop hypoglycemia. Now, your rapid-acting insulin, or your Humulog, the onset is about 15 minutes, and it peaks in 30 to 90 minutes. Therefore, you better have the tray on the floor before you give this injection of insulin. Your short-acting insulin, such as your Humulin R, has an onset of 30 minutes and a peak of about 2 to 4 hours. Your intermediate-acting insulins, including Humulin N and Humulin L, have an onset of 1.5 hours with a peak of 4 to 12. And your long-acting insulins, or your Humulin U, has an onset of 4 to 8, a peak of 10 to 30, and a duration of greater than 36 hours. Now, they also come pre-mixed. You have Humulin 50/50 with an onset of 15 to 30 minutes, a peak of an hour to 5, and it lasts about 22 hours. You have Humulin 70/30 with an onset of 15 minutes, a peak of 1 to 4 hours, and it lasts 18 to 24. And you have Humulogs 75/25 with an onset of 15 to 30 minutes, a peak of 1 to 7 hours, and lasts 24. Now, the objective is to mix and match these types of insulin so each individual person achieves good glucose control. However, if you run into issues with hypoglycemia, where the patient is sweating, they're very clammy and cold, they may be very irritable, and they may shake, the first thing you want to do is check your blood glucose, because that's going to help determine how many grams of carbohydrate you're going to give them. If it's less than 50, you're going to give them to 20 to 30 grams of carbohydrate. If it's between 50 and 70, you give 10 to 15 grams of carbohydrate. And then you're going to recheck in another 15 minutes to see if they need more carbohydrates. So this concludes our lecture on the diabetic emergencies.